Discover the 2 essential legal and ethical rules you must know when a patient refuses care. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-certified nephrologist, certified hypertension specialist, internal medicine specialist. See video description for disclosures. A 33-year-old woman presents to a U.S. emergency department with 1 day of throbbing right-sided headache, palpitations, malaise, and home blood pressure readings that have remained elevated for 6 months despite adherence. She reports an audible abdominal whooshing when supine and intermittent orthostatic lightheadedness without syncope. She denies chest pain and exertional dyspnea. Her history includes systemic lupus erythematosus diagnosed at age 22 without current nephritis, anterior uveitis in remission, and bilateral carpal tunnel syndrome. Her mother had carotid artery dissection in her 40s. She follows a vegan diet, is a former smoker who quit 5 years ago, and uses no alcohol or illicit drugs. She has regular menses and no known pregnancy. She has no medication allergies and reports fragrance-triggered headaches. Home medications taken this morning include amlodipine 10 mg by mouth daily, carvedilol 12.5 mg by mouth twice daily, hydrochlorothiazide 25 mg by mouth daily, lisinopril 10 mg by mouth daily started 3 weeks ago, ibuprofen 400 mg by mouth up to 3 times daily as needed for headaches used twice this week, prednisone 5 mg by mouth daily, hydroxychloroquine 200 mg by mouth twice daily, vitamin B12 1000 micrograms by mouth daily, depomedroxyprogesterone acetate 150 mg, intramuscular every 3 months with the last injection 7 weeks ago, and cetirizine 10 mg by mouth daily as needed for seasonal symptoms. Triage vital signs are tympanic temperature 38.4 degrees Celsius, repeat oral temperature 37.8 degrees Celsius, manual radial pulse 138 per minute and regular, respiratory rate 14 per minute, blood pressure 107 over 53 millimeters of mercury, and oxygen saturation 91% on room air that improves to 97% with 2 liters per minute by nasal cannula. She is alert, oriented, communicates choices coherently, and repeats risks and benefits. Fundoscopic examination shows mild arteriolar narrowing with arteriovenous nicking but no cotton wool spots or papilledema. Cardiopulmonary examination shows no murmur or rales. The abdomen is soft with a prominent systolic bruit maximal in the right periumbilical and flank region. Peripheral pulses are symmetric without bruits, and there is no lower extremity edema. Tinel sign is present at both wrists. Slit lamp examination shows no active anterior chamber cells. Initial emergency department results show regular narrow complex tachycardia at 138 per minute on electrocardiogram and no infiltrate or effusion on chest radiograph. Sodium is 138 milliequivalents per liter, reference 135 to 145 milliequivalents per liter. Potassium 5.3 milliequivalents per liter, reference 3.5 to 5.0 milliequivalents per liter. Bicarbonate 23 milliequivalents per liter, reference 22 to 29 milliequivalents per liter. Glucose 96 milligrams per deciliter, reference 70 to 140 milligrams per deciliter. And creatinine 1.4 milligrams per deciliter, reference 0.5 to 1.1 milligrams per deciliter, increased from 1.2 milligrams per deciliter 1 week earlier, reference 0.5 1.1 milligrams per deciliter. Estimated glomerular filtration rate is approximately 51 milliliters per minute per 1.73 square meters today, reference at least 90 milliliters per minute per 1.73 square meters versus 61 milliliters per minute per 1.73 square meters previously, reference at least 90 milliliters per minute per 1.73 square meters. White blood cell count is 9.2 times 10^3 to 3 per microliter, reference 4.0 to 11.0 times 10 to 3 per microliter, with neutrophils 72%, reference 40% to 70%. Hemoglobin is 12.8 grams per deciliter, reference 12 to 16.0 grams per deciliter. Platelets are 274 times 10 to 3 per microliter, reference 150 to 450 10^3 per microliter. And lactate is 1.2 millimoles per liter, reference 0.5 to 2.2 millimoles per liter. Urinalysis shows specific gravity 1.018, reference 1.005 to 1.030, protein 1 plus, reference negative, 0 to 2 red blood cells per high power field, reference 2 red blood cells per high power field, and negative nitrites and leukocyte esterase, reference negative. 2 peripheral blood culture sets are pending. Bedside renal ultrasound shows a right kidney length of 8.8 centimeters and a left kidney length of 10.6 centimeters, preserved cortical echogenicity, and no hydronephrosis. She declines contrast-enhanced imaging, and formal vascular laboratory duplex ultrasound shows right proximal renal artery peak systolic velocity 395 centimeters per second, aortic peak systolic velocity 92 centimeters per second, renal aortic ratio 4.29, delayed intrarenal upstroke with acceleration time 0.12 seconds, and a tardus parvus waveform. Left renal artery velocities and waveforms are within reference ranges. Outpatient testing last week showed plasma renin activity 8.2 nanograms per milliliter per hour, laboratory reference 0.23.3 nanograms per milliliter per hour, plasma aldosterone 24 nanograms per deciliter, laboratory reference 4 to 31 nanograms per deciliter, aldosterone renin ratio 2.9, screening reference less than 20, morning cortisol 16 micrograms per deciliter, reference 5 to 25 micrograms per deciliter, thyroid stimulating hormone 2.0 milli-international units per liter, reference 0.4 to 4.0 milli-international units per liter, and 24-hour urinary fractionated metanephrines within laboratory reference ranges. After oral acetaminophen and 1 liter isotonic intravenous crystalloid, her oral temperature is 37.8 degrees Celsius, pulse is 108 per minute, blood pressure is 118 over 66 millimeters of mercury, and oxygen saturation is 97% on room air. Cognition remains intact. The senior resident proposes immediate computed tomography angiography of the renal arteries using low osmolality iodinated contrast and, if a tight stenosis is confirmed, same-day revascularization. The patient explicitly states, "I do not want any contrast study until I speak with my partner. I'm okay with ultrasound today." An immediate serum human chorionic gonadotropin has been sent and is pending. Which single course of action is most appropriate from a legal and ethical standpoint right now, given this clinical context? Option A. Invoke an emergency exception after a 2-physician concurrence and obtain computed tomography angiography now using reduced-dose iohexol with prophylactic hydration, proceeding to same-day revascularization if severe stenosis is seen, because delaying imaging could risk end-organ injury despite the patient's current refusal. Option B. Confirm and document intact decision-making capacity. Record informed refusal in a contemporaneous note. Await the immediate serum human chorionic gonadotropin. Defer all iodinated and gadolinium-enhanced imaging today. Continue non-contrast evaluation and supportive care. Revisit written consent with interventional radiology later only if she subsequently agrees. Option C. Telephone her mother to obtain surrogate permission and schedule diagnostic catheter renal angiography with planned angioplasty under moderate sedation today, documenting capacity concerns afterward if disagreement persists, because time-sensitive procedures may be authorized by surrogates when patients hesitate in the emergency department. Option D. Respect aversion to iodinated contrast, but proceed immediately with non-contrast renal magnetic resonance angiography using time-of-flight sequences without obtaining the pregnancy test result or additional consent, because absence of contrast reduces risk and avoids delaying definitive vascular imaging. The correct answer is option B. Confirm and document intact decision-making capacity, record informed refusal in a contemporaneous note, await the immediate serum human chorionic gonadotropin, defer all iodinated and gadolinium-enhanced imaging today, continue non-contrast evaluation and supportive care, revisit written consent with interventional radiology later only if she subsequently agrees. The most appropriate immediate course is to respect the capable patient's informed refusal while continuing safe, non-contrast assessment and supportive care. She is alert, coherent, able to repeat the risks and benefits, and explicitly refuses contrast-enhanced imaging until speaking with her partner. Those findings support intact decision-making capacity. Her transient tachycardia, borderline oxygen saturation, and initial temperature improved after acetaminophen and isotonic fluid. She has no encephalopathy, pulmonary edema, acute coronary syndrome, stroke syndrome, or other immediately life-threatening manifestation requiring treatment over objection. The duplex findings strongly support right renal artery stenosis, but they do not eliminate her right to decline contrast imaging or same-day revascularization. An emergency exception does not permit a clinician to override an informed refusal by a capable adult merely because a diagnosis may be clinically important. A two-physician concurrence, reduced-dose iodinated contrast, prophylactic hydration, and concern for possible kidney injury do not create authority to proceed. Her mother cannot serve as a surrogate while the patient retains capacity, and moderate sedation cannot be used to bypass her decision. The pending serum human chorionic gonadotropin further supports deferring elective contrast-enhanced imaging, but the refusal alone is sufficient. Non-contrast renal magnetic resonance angiography may sometimes be discussed, but it still requires the patient's consent. It is not appropriate to proceed immediately after she has accepted ultrasound only and asked to delay further imaging. Time-of-flight techniques also do not automatically provide definitive renal artery characterization. In summary, capacity plus explicit refusal requires deferral of non-emergent contrast imaging and invasive treatment. Documentation should record capacity, the discussion, the refusal, alternatives, and the follow-up plan. Supportive care and non-contrast evaluation should continue while pregnancy testing is pending. Primary teaching point: a capable adult may refuse recommended testing or treatment, even when clinicians believe it is beneficial. Secondary teaching point: the emergency exception applies when urgent treatment is necessary and valid informed consent cannot be obtained, not when a capable patient refuses. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.